So, I mean, first of all, thanks very much for inviting me to give this talk, to give this opportunity. My name is Jonas Ludvigsson, and as Bert just mentioned, I'm a pediatrician and also a professor of epidemiology, and I'm going to talk about Swedish healthcare registers. And first of all, of course, I guess the opportunity that I have to give this talk is partly because I share an interest with Bert and with many others in research infrastructure, and I've written a number of review papers of important registers used in register-based research in Sweden, many of them published in the European Journal of Epidemiology. But also, of course, another reason for being able to give this talk is my tremendous collaboration with many of you. And I think we've co-published about 100 papers with people at Harvard MGH. So first, my disclosures. I have received funding from Janssen for an unrelated IBD study. I've also received funding from MSD for a study on Chinese healthcare registers. And finally, I have received money from Takeda for an ongoing celiac disease study. I just see if I can take away this meeting is recorded panel because it is a bit annoying. Okay, sorry, my apologies. But also, I've written a book about the diseases and death in Harry Potter, published on Amazon.com. And every time you buy a copy, I and my co-author earn about 10 cents. And last time I checked, only 2.3 million books were more sold on Amazon. So hence a true success. I think my interest in epidemiology started in 1994. That's about 30 years back. And it was a study published in the New England by another Ludvigsson, actually my father. And I mention this because when I started to do research, my father encouraged me to use my middle initial so that our publication would not be mixed up. Actually, when I was 25, a friend of mine asked me, how's your research going? And I told him, well, please have a look at PubMed. He came back and said, you published 300 publications already. Of course, these were not my publications, but my father's publications. So I did take advantage of JL. Sometimes I also joke that it's because I have a lot in common with another JF. So this is JL, JFK, and JFL in the same slide. For the next 35 minutes, I hope to tell you about the personal identity number in Sweden, which is needed for linkages and also to keep track of the Swedish population, total population. I will say a lot of and focus on different registers in Sweden, and then I hope there will be some time for questions. I would say that the diamond of the register crown, so to say, in Sweden is the personal identity number. And this is a unique number. Without it, there would be no large-scale linkages in Swedish epidemiology. And the personal identity number, or sometimes abbreviated as PIN, is based on three parts. It's based on your date of birth, here 490808, and then a 3-digit birth number, where the last digit is even in women and uneven in men. So here 7 would be uneven, and then go with a man. And then you have a final digit, which is a check digit or a control digit. And that one is calculated based on the preceding digits, these preceding 9 digits, in a quite complicated way. And that is a way to obstruct fraud, to make it more difficult to come up with a fake personal identity number. The personal identity numbers traditionally were used a lot in healthcare, where they're still very much used, but we used to print them on these plastic cards, which all Swedes carried with them and showed when they entered a hospital or a healthcare center of some kind. Now, of course, everything is digitalized, but we still use the personal identity number a lot. The first register I would like to mention is this. It's the register of the Swedish total population. And this is a paper I wrote some years back. And here on the picture below, you can see the different Swedish age groups, different age groups over time, where, of course, I have a special interest in the youngest people, since I'm a pediatrician. the total population register covers the complete Swedish population, and it has a very high coverage of data on births and deaths. And most of these are reported within 2 days, or actually immediately these days when things are even more digitalized. We also have very good data on immigration and emigration, although the recording of immigration and emigration is sometimes somewhat delayed. We have slightly less coverage of migration within Sweden, since especially some students do not update their residence when they move to a university city, for instance. As part of the total population, we also have first-degree relatives and relationships. This is sometimes called the multi-generation register, but the multi-generation is part of the total population register. And through this register, you can link data between, for instance, an individual with his or her father, mother, siblings, kids. And that will help you to do some very groundbreaking research. Actually, this is a paper I wrote together with Mingyang Song, who I just saw attending this session. And they we looked at polyps in first-degree relatives to see whether that was associated with an increased risk of colorectal cancer, a study we later published in the BMJ. I've also been using the multi-generation register, or the total population register, to study, for instance, heredity, drug exposures in first-degree relatives. And this means, for instance, when you look at exposures in pregnancy, that you can look exposure in the father as some kind of controlled measure. 2 government agencies, or perhaps 3 government agencies, are responsible for maintaining the most important registers that we use in Swedish epidemiology, or register-based research. The first one, maintaining the blue columns, bars, registers, is Socialstyrelsen, which is the National Board of Health and Welfare. And they maintain registers such as the cause of death register, the medical birth register, the cancer register, and the patient register. Well, all important nationwide registers, including the prescribed drug register, which I've not included in the slide. The green agency, SCB, Statistics Sweden, which has its headquarters in my hometown, that's why I mentioned Örebro there at the top. They maintain data on, for instance, education, which we retrieve from the so-called LISA database, but also on migration and date of death, which can be retrieved from the total population register, which I just mentioned. Then we have a third agency, and that is the tax agency. The tax agency is formally responsible for the personal identity number and for the total population register, but the total population register is updated and mirrored back to Statistics Sweden every day, on an everyday basis. So as a researcher, you retrieve data, you get data from Statistics Sweden, even though formally the tax agency is responsible for the population. So how do we go about to assign diagnosis, the basis of a lot of research? I will say a few words about the patient register, which would serve as a model for other registers in this presentation. And I work as a physician. I work in the clinics 3 days a week, Wednesdays, Thursdays, Fridays. And every time I see a patient in the ward or in the emergency department, I assign a diagnosis. The most important diagnosis is the main diagnosis. And then, of course, I can also assign secondary diagnosis. I either register them myself in the electronic healthcare system, or I ask a secretary, that's the most common, for him or her to register these diagnoses. And then they are transferred to the National Board of Health and Welfare and merged to form the patient register. For a register or a healthcare register to be valid, it needs to have certain characteristics. And Swedish registers actually cover the individual, follow the individual from the cradle to the grave. And among these features which are needed for a successful register is sufficient follow-up and no loss of follow-up. And actually, the Swedish registers have very long follow-up. They started a long time ago, many of them. In 1952, cause of death register. 1958, cancer register. In 1964, the patient register started, initially covering just a minor part of Sweden, but then growing. 1973, the medical birth register started. 1987, the patient register became complete. And in 2001, I've added that year as well, we added hospital-based outpatient data to the patient register. So long follow-up data since many years back. A second feature which is important is coverage. And we have good coverage of what's happening in healthcare in Sweden because of a comprehensive universal access to healthcare. And here is the kind of healthcare covered by the patient register. The patient register covers hospital-based outpatient and inpatient care, as well as day surgery. It should also, on paper, cover private healthcare. It does to a large extent, but not perfectly. However, that is only a minor drawback in Sweden, since private healthcare makes up a very small proportion of Swedish healthcare. But what it does not cover, the nationwide registers, is the primary healthcare. Here illustrated by a photograph of my wife's primary healthcare center, since my wife is a GP. There are ongoing discussions in the National Board of Health and Welfare to include also primary healthcare in the patient register, but it has not happened yet. The coverage of these registers is usually high, and here I exemplify with the patient register and the somatic coverage. As you can see, it started in 1964, and the blue line here illustrates the minimum coverage, the red line, the maximum coverage, because we do not really know up until 1987 when we have complete coverage. The psychiatric coverage, or coverage of psychiatric disease, is somewhat different. Then we had no coverage until 1973, and from 1973 we almost have complete coverage immediately. The third feature which is needed for a successful healthcare register is quality, and we have high quality. I usually say that the diagnoses which are deadly or which require some kind of intervention probably have the highest PPV, positive predictive value, or highest validity. When I'm in the emergency department and I see a child with a fever, some cough perhaps, and a low CRP, I usually assign them the diagnosis viral infection, B34.9 in ICD-10. I don't care much about whether that diagnosis is super valid or not, and I'm not sleepless for assigning an incorrect viral diagnosis to a child who is otherwise healthy and doesn't need any intervention. But I would never assign a diagnosis of myocardial infarction to someone without a positive ECG, probably some symptoms, and then increased troponin levels. So no one I know would assign a diagnosis of myocardial infarction without extensive investigation. No one I know will assign a diagnosis of leukemia without extensive investigation. So these deadly, severe diagnosis with the need for intervention, they will have a high validity and a high positive predictive value. And to give just two examples, acromegaly was reviewed according to patient charts, and we found that 76% of those with the diagnosis were very likely to have, or well, we were completely sure they had acromegaly. Another 14% were likely to have acromegaly, and in total 90%. In IBD, we tend to require two diagnoses of IBD to call this IBD, and then we have a PPV of 93%. If you also combine with histopathology, the PPV actually rises to 95%. And here, in the left-hand corner of the slide, you can see other PPV values: angina pectoris 95%, hip fracture 95%, preeclampsia 93%, Addison somewhat lower. But of course, we do have problems with incorrect diagnosis. If we have thousands of people with Crohn's disease who should have been assigned a code of K50, then just through human error or transcription errors, a few will actually be assigned C50 because it's almost K50, and then suddenly have a breast cancer diagnosis. We also have these patients in the patient register who have a diagnosis of eczema, and then suddenly they have one diagnosis of ischemic heart disease, myocardial infarction, in the department of dermatology. Of course, that's L20 being incorrectly transcribed as I20 instead. So you need to be aware of this, but it's rare. Another problem is that some physicians will assign a diagnosis and then add investigated for or suspected, but that is actually just as assigning the diagnosis. because there is no such thing as investigated for or suspected for in the patient register. And then, of course, sometimes we make an initial diagnosis which turns out to be incorrect. For instance, patients with IBD where I first say this Crohn's disease and later it turns out to be UC, then the first diagnosis is incorrect. There are several ways or approaches to increase the specificity of some of these diagnoses. One is using the main diagnosis in a sensitivity analysis. Another is to only accept those diagnoses recorded in certain clinics where the diagnosis of interest is common and well known, like a GI diagnosis in the medicine department, surgery departments, perhaps pediatric departments in the GI departments, but not accept a one-time GI diagnosis in the Department of Dermatology, Rheumatology, or Nephrology departments. We can also combine an ICD code, a medical diagnosis with drug use, like having both a type 1 diabetes diagnosis and insulin in the prescribed drug register, of course, increases the specificity. You can combine a medical diagnosis with, for instance, histopathology data that I typically do, or acquire at least 2 records of a diagnosis, as in the case of IBD. This is what the patient register looks like, the data when you receive it from the National Board of Health and Welfare. In the left-hand column, you can see LPNR, that's shortening for loop number or serial number, which is a number that replaces the personal identity number because data are delivered pseudonymized. That is, the personal identity number is replaced by a serial number. And if an individual has the individual number 84 at the bottom, has more than 1 hospital admissions or 1 hospital contact, each contact will yield 1 row. So this person, in this example, 84, has 3 visits. And then you have sjukhus, which means hospital. You have kön, which means sex, alder, age, in date, out date, year, etc. And sometimes we combine these registers. This is a study together with my former PhD student, Ola Åhlén, where we combined ICD codes from the patient register with histopathology data from my cohort study that I'll get back to, with the cancer register, and then study colorectal cancer in ulcerative colitis, a paper published in The Lancet a few years ago. Here is a view of the medical birth register. As you can see, it looks quite similar, but with slightly different variables. The medical birth registry was created in 1973. Actually, we just recently published a review of this register in the European Journal of Epidemiology with Sven Knatingius and others. In 1982, smoking was added to the data. In 1992, body mass index was added, and the register is based on several forms. I want to stress that the medical birth register actually contains data on smoking and body mass index because it is the only nationwide healthcare register maintained by the National Board of Health and Welfare, which does contain smoking and BMI. That is usually a limitation of Swedish registers. If you want to find large-scale data on smoking and body mass index, your best bet is usually to go to a quality register. And for those of you who are interested in that, I recommend the review of 103 Swedish healthcare quality registers published by my former PhD student, Louise Emilsson, who actually did a postdoc at Harvard and collaborates with both me and Ming Yang. Well, back to the medical birth register. The medical birth register also uses the personal identity number as its identifier to enable linkages. And as I mentioned, it has data on BMI and smoking, but also listed there parity. We have data on civil status of the mother. We have data on earlier infertility, whether it took time for the mother to become pregnant. We actually have some data on placental weight, and importantly, we have data on the child as well. So this is the only healthcare register which combines data from 2 individuals, both mother and child, and there is 1 row for each birth. So a mother can have several rows. And we also have data on APGAR score. And here just a sample of this Virginia Apgar, a real role model. She was both a pediatrician and an anesthesiologist. She is said also to be an accomplished violin player, and died from progressive liver disease, probably due to exposure from all the anesthesia. We can combine also the patient register and the medical birth register. And here's a study I published in Gastroenterology almost exactly 20 years back, where we looked at undiagnosed celiac disease and found that compared to control women, children born to women with undiagnosed celiac disease were at increased risk of very preterm birth and very low birth weight, while diagnosed celiac disease had no such associations. Over to the cause of death register. The cause of death register has been around for more than 50 years now. And this picture here shows the most common causes of death in both males and females. As you can see, initially, the dark green, that's children die from cancers, for instance. And then in young adulthood or adolescence, there will be more suicides, unfortunately, some traffic accidents, and then over time, cardiovascular disease and cancer will become more dominant. A similar picture is seen in females. And here's one example where we used cause of death register. We combined histopathology data with inpatient data and then also cause of death data, and looked at mortality in celiac disease, a paper together with some of my collaborators at Columbia. Over to the cancer register. The cancer register was started in 1958, and every year in Sweden we have about 70,000 new cancer cases. This register has an estimated coverage of about 96%. And here in this table, I've pasted some of the variables, some of the most important variables of that register. There are more variables, but you can see here, you have age, you have year of diagnosis of the cancer, whether the tumor was benign or malignant. You can look at death date in those who died. You can look at some specific date on breast cancer, some specific date on gynecological cancers, tumor localization, clinic, place of living, presence of metastasis, lymph nodes, etc. And there are more data. Since I give this talk being in Boston, or at least to a Boston audience, I also just want to mention this, that at the Dana-Farber Institute, they have this Jimmy Fund, and actually the Jimmy Fund to eliminate cancer, I know many of you are interested in cancer, was founded when Dana-Farber had their first kid who survived leukemia, I think from being treated. And that was actually a Swedish boy. His name was Einar Gustafsson. But when they were going to create a fund in his memory, he did survive, but still, to honor him, people thought Einar was such a difficult name to pronounce that they simply called the fund Jimmy. But his name was Einar, and he was a Swedish boy. Over to my last register, and that is the prescribed drug register, which started in 2005. The reason for initiating this register in Sweden was that the government realized they wanted to track potential side effects from Vioxx. And in the content, we have dispensed items. We have the amount and the dosage of the drugs. We have place of residence of the patient. We have also date of prescription and of dispensing, and also the profession of the prescriber. We do not have data on vaccination. Sweden has initiated or launched a register of about covering COVID-19 vaccinations, but other vaccinations are not in the national healthcare registers. Neither do we have good data on biologics or chemotherapy in these registers, since the register is limited to prescribed drug. But what we do have is we have the whole population. We have all prescriptions, also prescriptions from the primary care. And that's important because it means we can sometimes use primary care prescriptions as proxies for certain mild disorders, as a way to identify mild asthma, as a way to identify constipation, etc. The prescribed drug register can also be used to analyze aggregate data and get a feeling. For instance, how many children in Sweden aged 0 to 4 years received antibiotics during a 6-month period? Well, 20%. And these data are a bit old, so these days perhaps 15%. How common are lipid-lowering drugs? Well, 15 to 20% in some age groups, higher in some age groups. And aggregate data can also be used to examine burden of disease. analyze costs, socioeconomic patterns for prescriptions and treatment, etc. At the same time, we have to acknowledge there are problems with drug data in any data set, but also in the prescribed drug register in Sweden. For instance, an association with an outcome may be due to the medication, but could also be due to underlying disease activity. And that was the interpretation of the findings in this study, where we studied mortality in IgA nephropathy. I did that with one of my PhD students, Simon Jarek, where we found an association, positive association with steroid use, immunosuppressant use, and RAS inhibitor use in IgA nephropathy and mortality, which we interpret rather reflecting underlying disease activity than the drugs themselves. And then, of course, people sometimes have a prescription but still do not take their medication. There is some data indicating that in Sweden, 50% of patients take their drugs. It's, of course, much, much higher when it comes to certain disorders like type 1 diabetes, because if you don't take the drug, you die. But for some medications which are more of voluntary, so to say, or optional, the compliance may not always be 100%. And sometimes also patients stop, and those who stop may have more side effects than those who continue. So it's a bit too tricky. The final extreme example is, of course, that not all medication use is recorded, because you may use drugs from someone else. For instance, you have a headache, you walk over to your neighbor, and your neighbor says, well, why don't you take this pill? It will make you feel great, and you take it. So a few real-world examples from the registered world. Here's one of my favorite examples from my colleagues from my department, Paul Lichtenstein and Henrik Larsson, where they looked at patients with ADHD and could see that those being on an ADHD medication had a lower risk of committing crime. Another example is this one with colleague Yasmina Molera, where we limited our data set to women who were smokers in the medical birth register. And then we looked at time periods with and without nicotine replacement, that is smoking cessation drugs. And we could see that during periods when mothers had a prescription of nicotine replacement, the incidence of respiratory syncytial virus in the kids, or the need to be admitted to hospital for obstructive bronchitis, went down by 20–30%, which I think was quite elegant. We've also studied the use of tumor necrosis factor inhibitors, anti-TNF-alpha, and the risk of infection in IBD, both in Danish and Swedish data. And many of you have probably seen this paper together with Tracy Simon, Raymond Chung, Andy Chan, and others, where we looked at aspirin use in hepatitis and the risk of HCC and liver-related mortality. Another study by Long-Yan Nguyen, also Mingyang Song, other collaborators, Tracy Simon, Yin Sao, Andy, Kyle, etc., Hamid. This was a straightforward case control study where we looked at IBD patients versus controls and tried to see if earlier antibiotics was a risk factor for IBD, published a few years ago in the Lancet Gastro. All the earlier registers that I mentioned can actually be combined with your own data. And here I've chosen 3 drawings that I made during a trip in Italy to illustrate my own cohort study. As you can see, I'm quite fond of Italy. And I was looking for an Italian name for my study and came up with the study name Espresso. Only later did I have to find out what does espresso actually represent, and I came up with epidemiology strengthened by histopathology reports in Sweden. I was so happy about the espresso acronym that I just had to keep espresso. And this histopathology-based study covers 2.1 million patients with a histopathology record from the GI tract. And in total, they have 6.1 million biopsy reports, and it's currently being updated. And I think we will have an updated biopsy database this autumn. And it's based on computerized biopsy reports from the GI tract, including the liver, where we have 350,000 biopsy reports, the gallbladder, about 250,000 biopsy reports. You can see the stomach, 1.2 million, colon, 1.6 million, rectum, about 800,000 biopsy reports. And if you want to know more about this study, I suggest you Google YouTube Ludwigson and espresso, and it will take you to a short introductory movie. If you just Google Ludwigson and espresso, it will take you to the study webpage. Please do so. So to conclude my talk, Swedish registers are cost effective because the data have already been collected. They're collected as part of routine healthcare in Sweden, where almost all healthcare is government assisted and almost free of charge. It's population based with virtually complete follow-up. It's non-selected because you cannot opt out. It's all your data are registered whether you like it or not. It's seen as the contract between the individual and the healthcare in Sweden. It means that we will include both poor and rich. Data are not influenced by one's hypothesis because data are collected as part of routine healthcare, which also means it is, as I said, very cost effective. And then when you ask for data, you will almost always receive anonymized data, or rather pseudonymized data will personal identity numbers have been replaced by loop numbers or serial numbers, and then some data undergo a quality review before being delivered to researchers. So, of course, I would have liked to give this talk in person, but at least I support the right team. Here I am in Sweden with Hamid Khalili, longtime collaborator during Hamid's latest visit to Sweden. Hamid, if you hear me now, I hope you'll come back soon. And with that, I would like to thank everyone for listening, and I'm happy to answer any questions. This is a photograph taken during my last visit to Boston, and I hope to be back in town in person this autumn. Thank you very much.